Welcome to the Industrial Athletic Trainer Society On-Demand Continuing Education Program. In this session, you'll gain practical, evidence-informed insights designed to enhance your effectiveness as an industrial athletic trainer and support the health, safety, and performance of the working population. If you find this video valuable, be sure to like, comment, and subscribe to stay connected with future content from the Industrial Athletic Trainer Society. Society members, once you have viewed this video, stick around at the end for instructions on how to claim your CEU. We hope you enjoy the content. Let's get started.
CEUs that we were trying to get knocked out. We brought up DEI, and I was like, I think maybe I have a connection. Let me see.
Well, I'm glad we have that connection.
Yes, me too. Alrighty, we will go ahead and start off with the introduction. So thank you all for joining us today for Understanding Patient Values, an essential component of patient care. Today with us, we have Dani Moffit. She's a professor and the program director for Master of Science of Athletic Training at Idaho State University. Her previous positions include the program director for the undergraduate athletic training program at Temple University in Philadelphia and teacher/athletic trainer for the Meridian School District in Meridian and Eagle, Idaho. In addition to her faculty position, she volunteers at the Pocatello Free Clinic and with local events. Her research areas include cultural competency in healthcare professions and sexual misconduct in athletic training. So I'm going to go ahead and let Dr. Moffit take over. We can go ahead and put any questions in the chat along the way, and we'll revisit them at the end.
Okay, great. Thanks so much, Megan. First of all, I just want to thank the Industrial Athletic Trainer Society for inviting me to speak today, because this is a topic that I'm very passionate about. You can take a look at the objectives. These are very few. I just had to put some in. We're going to be talking about a lot more than just this. I do not have any conflicts of interest, but I think it is important to note that I am a white, privileged female. So as much as I think I know about cultural competence, it's never going to be, and patient-centered care, it's never going to be without the understanding that I can never truly understand the depth to which other people are experiencing. So there's 5 things I have on here, and I always like to start my presentations with this. So these are parts of who you are in one way or another. What I want you to do is I kind of want you to look at these, and I want you to rank them of importance. You don't need to say, you know, I'm male, female. You don't need to say what political affiliate. I just want you to say, you know, what is the most important here, and kind of rank these. And normally I would have you write these down and put them on a piece of paper. For today's activity, I'm not going to make you do that. But what I want you to do, you now have them ranked 1 through 5. And what I want you to do is I want you to take number 5 and get rid of it. And now I want you to take number 4 and I want you to get rid of it. And now I want you to take what you ranked as the 3rd most important and get rid of it. And so you're left with your 2 most important pieces of who you are. Normally, I would say, okay, turn them upside down. I want you to mix them up, and I want you to get rid of one of them. And since I didn't have you write them down, I want you to think about the fact that you had 2 left, and now you have to get rid of one of them. And if you were doing it randomly, or if somebody took that piece of paper from you and left you with only one, how does that make you feel to destroy something that is really a part of who you are? And how does it make you feel that maybe you wouldn't get to choose which one to destroy? That's how people feel on a daily basis when you're working with them and you're not looking at their true identity and who they are. And if you have ever felt like you aren't in control, or you've been marginalized, or you haven't been given a choice, this is what a patient might feel like if you are overlooking important parts of their identity. Here is a little timeline of the history of patient-centered care. And if you look at where it started, 1950, the same time that athletic training started, that's when people started talking about patient-centered care. So it really hasn't been something that's been discussed for very long. And if you look here, this is specifically to athletic training. Athletic training really didn't have its first article about patient-centeredness until 2009. And so it really hasn't been a focus of discussion in our profession since that time. And if we look at patient-centered care, it really is a philosophy of care that encourages three different things: shared control in the consultation and decisions about intervention by that patient, as well as a focus in the consultation on the patient as a whole based on individual preferences. And those preferences may be within the social context versus how it used to be based on the body part or the disease itself. And then treating patients as partners and involving them in planning their health care and encouraging them to take responsibility for their own health. And so it's helping your patients become medical decision makers, taking an active role in their own care. Honestly, I think that athletic trainers innately are really good at this because we have a relationship with our patient, but we always need to be reminding ourselves to keep the criticality of this concept at the forefront of the care that we serve to our patients. Most of us were probably taught in more of a medical model because we needed the knowledge to pass a national exam. But in reality, we need to work on the patient-centered model for optimal results. And you can see some of these differences here. And I'm not going to go through them. You're going to have this presentation so you can take a look at them. But just understanding that we really need to look at quality of life and making that a patient-centered, making that patient-centeredness for them. When there is a lack of patient-centered care, there tends to be more non-compliance, poorer health outcomes, a distrust in the healthcare system, poor patient-reported outcomes, decreased use of health resources, a lack of trust in the provider, and unfortunately, studies have demonstrated that when providers behave behave in a way that devalues patient views, deliver information poorly, or fail to be attentive to the patient's perspective, often are more likely to face malpractice claims. And so part of patient-centered care is taking into consideration the multiplicity of factors that shape the patient's life that is sitting or lying in front of you. And we need to keep these in mind. When we are practicing truly patient-centered care, we are looking at the whole patient view. Most clinicians will say that they are incorporating aspects of physical and mental health, but we also need to consider the social determinants of health for these patients. And social determinants of health are things that many of us may not have ever learned when we were in school because it wasn't a big focus, but these are your personal, social, economic, and environmental factors that are going to influence the individual and the population health. These are considered the conditions here in which people are born, grow, live, play, and age. It is really vital that these are contributing factors to the care that you are providing, the policies that you are implementing, or the prevention strategies you are focusing on. Addressing social determinants of health is very important for improving health and reducing health disparities. So in the next few slides, I'm going to walk through the different social determinants of health. And as I'm doing so, it really encourage you to think about things that you as an athletic trainer can do for your patients in each category. Economic stability incorporates a lot of different pieces like employment, income, expenses, debt, medical bills, and the support that they can receive. Now, I am from Idaho, and so the stats I'm going to share with you are from Idaho, but realize that they're probably pretty similar regardless of where you live in the United States. And this was, these are stats from 2019, so that was prior to the pandemic. But in a 2019 estimate, 10% of Idaho residents live below the poverty line. However, according to the most recent census data, that was about 9% of Idahoans not having health care coverage, which was compared to 8% of the US. So we've got many people who can't afford things like healthy foods, healthcare, and housing. And if we consider these factors, we need to think about how can we support our patients when it comes to things like referral, information on the nearest food banks, or information on free or reduced medical clinics for referrals. By knowing these things, we're supporting our patients. And then on the flip side, if people are unable to work because they have short or long-term consequences from an injury or illness, this is going to impact that economic stability. If we can work to prevent workplace injuries and or help return folks to work more quickly, we are contributing to the community. It's well known that people with higher levels of education are more likely to live longer and healthier lives. This includes not only educational level, but also literacy, language, early childhood education exposure, vocational training, and higher ed. As athletic trainers, we can help contribute to health literacy, both in the patients we are serving and their family or community. If we are providing them with information about prevention strategies or information and choices about their treatment options, we are influencing their experiences with the healthcare system. If you don't have health insurance, you have very limited access to healthcare. I volunteer at the Pocatello Free Clinic one afternoon a week, and I'm specifically helping with lifestyle medicine and orthopedic conditions. The Pocatello Free Clinic is the only free clinic in southeastern Idaho. We have patients that see us in a 150-mile radius. Additionally, the majority of my patients work at least one, if not two jobs, but because we are a right-to-work state, those jobs are minimum wage, and they only work them 30 hours a week, so they don't have to pay benefits. We have a set number of x-rays we can order each month. If a person needs to see a dentist, the wait is up to 3 months. Our clinic gives immunizations, provides vasectomies and circumcisions, and tests for STIs. Are there things that you can offer in your clinic that maybe your employees aren't able to get elsewhere? This determinant includes housing, transportation, safety, access to parks, playgrounds, walkability scores, and zip code geographical location. If you think about it, an athletic training facility is a built environment of its own, and we are often a safe haven for our patients and a place that they can come to for more than just evaluation and treatment. We know that people's relationships with other people have major impacts on their health and well-being. By building positive relationships with our patients, we are a part of their social and community support. Again, as part of the entry to the healthcare system, and because of the relationships that we have built with our patients, we are providing a sense of support. And because of these relationships, we also often are the ones that can identify risky behaviors or other issues and can refer out to help earlier on. The pandemic and the social justice movements from the past few years have really shown the isolation that people feel when they are not part of a community. When we return people to work and play, we are allowing them to return their community and hopefully free themselves from isolation. Before moving forward, I want you to take a quick self-assessment. I want you to think about some of these questions. And they can be things like, who am I? Racially, ethnically, and culturally? What are my class, religion, gender, sexuality, age? How is who I am now influenced by who I was before? And who do my parents, peers, and society say I am? What biases or prejudices do I hold towards individuals or groups who are different from me? Have I ever been cast into the minority status? And if yes, how did I feel? And if no, how might I feel if I get cast into this status? How can I grow? And who can I become? I can't talk about patient-centered care without bringing in culture. And why is that the case? Here are some stats. There are at least 2,500 cultures and subcultures that coexist on our planet. And many of the people who live in a different, or many people live in a different country from where their culture actually originated, and especially in the United States, because many of us, if not most of us, come from another country. Maybe not first generation. We could be fourth, fifth, sixth generation, but we probably came from another country. And we can't assume to understand someone's culture based on their race or origin. This is the definition of culture that I pulled. I'm not going to read it for you, but you can see that there are so many pieces and parts. And we have to take principles that provide the basis for this cultural competence. And I highlighted compassion in red there, because if you have been an athletic trainer for any time, you may remember several years ago when the NATA month theme was compassionate care for all. That is one of our basic levels of having cultural competence. And all of this matters in healthcare because our health belief system does not always match the health belief system of our patients. Again, if you went to went to school for athletic training in the United States, which majority of athletic trainers did, we were raised in Western medicine, and we were taught in Western medicine. We are expected to make it better as fast as we can, rather than waiting it out. We have protocols that we have set up for many of our different conditions, often doing the same thing for everyone. And I'm not saying that these are necessarily wrong, but they're not necessarily right either. And maybe we need to be comparing our beliefs to others from other countries. For all the good that Western medicine has given us, there is perhaps a lot missing that we could learn from others as well. As I said earlier, we can't talk about patient-centered care without bringing in culture, which means this continuum. And you may have seen this continuum previously, but it always requires self-reflection, because if you look at this continuum, you've got arrows on both ends, which means I need to look at where I am now and where I could be. And I need to understand that sometimes this is a journey, not a destination. And so sometimes we might backslide a little bit. But when we backslide, we can learn and move in a direction that's needed. I'm not going to define all the levels for you, but I want you to notice that cultural competence isn't the final level. As you move up to that upper right end, we have 2 more levels. Cultural proficiency is when folks begin to implement changes to improve services based on cultural needs. I don't love the term proficiency because it means almost good enough. We, as athletic trainers, want our entry-level athletic trainers to be proficient, which means they can go out and they can start working, but they need to continue to grow. And so we don't want to stop at that proficiency. We want to have cultural humility. And cultural humility is defined as the lifelong process of self-reflection and self-critique, whereby the individual not only learns about another's culture, but one starts with the examination of their own beliefs and cultural identities. This requires self-reflection. It requires a loss of ego. We need to move from look how much I know to there's so much I don't know and how can I learn more. We also need to understand history and how does the historical analysis of color, or how the historical analysis colors the relationship between you and your patient. Cultural humility has the responsibility to continually learn and address power imbalances when they exist. And this requires action to address systemic solutions. So what is your personal responsibility? I have 3 things here, and we're going to talk about many more of them, but you need to commit, you need to be intentional, and you need to embrace the journey your own vulnerabilities, and the fact that you aren't always going to be right and you won't always have the answers. In the at the end of the presentation, I have a list of a lot of different resources that you can look at, but I want to point out that one that is a great place to start is called it's an article called White Privilege, Unpacking the Invisible Knapsack. It's an article by Peggy McIntosh, and I have the link at the end of the presentation, but that's a great place to start, just to start thinking about where change can begin. One of the hardest parts of change is knowing what can be done to make that change. Campina Bocode created a 5-step process to work toward greater cultural competence. And so I'm going to kind of put these all in a nutshell for you and discuss each of these in the next few slides. So the first step is cultural awareness, which is also known as cultural intelligence. I love this statement that was made about Martha Stewart and Snoop Dogg, who are, really good friends right now. Be mindful about stereotypes, because if you look at this picture, who is a convicted felon? And many people are going to look at the felon, and who are they going to go to immediately? Snoop Dogg. Well, guess what? Martha is one also. But we don't always go that direction, because a white female is a convicted felon. Are you kidding me? Yeah. Cultural awareness involves a recognition of your own biases, your prejudices, and assumptions about individuals who are different from you. Part of cultural awareness is becoming aware of your biases, which we all have. You can't deny it. If you tried to deny it, you would be wrong. Those biases may be implicit or they may be explicit, and they're going to guide your everyday actions. Unfortunately, this has become very evident in our country in the past 10 months. Implicit biases may be something as simple as when a Black man does an awesome presentation, you say, "My, he's well-spoken," when what you really mean is, "My, he's well-spoken for a Black man." And this happens a lot. An explicit bias is one that you're aware of, but you still keep it as a bias. For example, my explicit bias is that freshman boys are stinky and whiny and have zero pain tolerance, and the last people I want to take care of when I'm working in my athletic training facility, right? You may not believe that, but that is my explicit bias. I know I have it, I just can't change it. We need to really consider what our values are and whether we are actually projecting it on the patients we treat. During COVID on NPR, I heard a story of a Black female physician who was in the hospital because she had COVID. The hospital decided to discharge her, and she told the nurses and the physicians that it was too early. She still needed to be there. None of her providers were people of color. She started filming the interactions on her phone that she was having because she was being told that she was being silly, she was being hysterical, and she didn't know what she was talking about. Remember, this woman was a physician. They discharged her, she went home, and less than a week later, she died from COVID complications. Do you have implicit biases toward a group of people? You may not know. At the end of the presentation, again, I've got the link to the Harvard Implicit Bias Test, so you can find out. It is a validated test that is very eye-opening to our own implicit biases, and I take it over and over, and I get really mad that I'm not getting any better because I think I don't have these biases, but this implicit bias test is showing me that I do. Implicit bias in healthcare could be a talk entirely on its own, but for now, I want you to consider some strategies that will help you to fight these biases and stereotyping. First of all, point it out. Be the person who points out negative preconceptions and openly talks about them. Be an example. Be a role model and respect people regardless of what society says about them. And then speak up. Challenge those around you to reflect and engage in open conversation. It may change how you even think. The next step in the process of cultural competence is cultural knowledge. Do you actively try to learn more about diverse cultural and ethnic groups that are in your community or that you work with in your facility? I grew up in Idaho. When I moved to New Jersey in 2002, I was 34 years old. I was 34 years old when I learned that not only do Jewish boys have bar mitzvahs, but Jewish girls have bat mitzvahs. I had never heard that term in my entire life. I didn't think I knew anyone who was Jewish until I moved, until I recently went to a funeral here in Idaho, and Mr. Cohen was there wearing a yarmulke. Then I realized, oh, I did know someone and went to school with someone who was Jewish, and I had no clue. I also learned that First Communions were a huge thing in Catholicism because I grew up as a Baptist in Idaho, and I only knew about the predominant religion that was other than mine, which was the Mormon religion. Do you as a provider try to learn about the cultures of the patients that you treat? Cultural skill is a process of learning how to communicate and being aware that there are differences in the culturals of the patients that you are working with. Again, we probably are practicing a lot of these cultural skills in many cases, but if you don't have cultural humility, you probably aren't thinking right now that we can become better in everything that we do. And asking questions becomes so important. We don't want to make assumptions. We want to ask. Cultural encounters basically is asking us to engage in cross-cultural interactions. The picture on the left is me with a group of my students from the years that I spent at Temple. They are the reason I'm passionate about the topic. And this was not a planned picture. We were all attending the Ethnic Diversity Advisory Committee town hall at our national meeting. And the only other white person in that picture was actually the clinical coordinator. So, those were our students. The point is that these are my kids. And do I see any differences on the outside? Yeah. But does it make a difference? Absolutely not, nor should it. I do everything I can when I'm working with my patients who may be a cultural identity from me to learn about them and understand that I need to learn about them so that I can treat them as I would any other patient who may have the same culture as me. And this brings us to the final component of the process, which is cultural desire. Do you want to become culturally competent, or do you have to? I'm going to be blunt. If you don't want to, what are you doing in healthcare? So why does it matter if we work toward cultural humility? Well, here are some reasons. The minority populations are going to become the majority in the United States, but there will not be a single group that makes up the majority. The non-Hispanic white population will remain the largest single group. By 2060, nearly 1 in 3 Americans will be Hispanic, which is the term that's used by the US Census. And the percentage of Black Americans will increase to 14.7%. Asian Americans will actually double to 34.4 million in 2060. So we are going to have a lot of diversity, and we need to know how we can best meet the needs of those patients. Our United States is changing. In the NCAA, over 50% of the student athletes are minorities. And we know that with minority patients, we have to know and understand medical conditions that affect these populations, like sickle cell trait, late onset Tay-Sachs disease, or albinism and blindness. So again, why do we need it? We have knowledge of what happens to ethnic and racial minorities. They tend to have less access to and availability of healthcare. They don't receive the healthcare services they need. They don't receive high quality healthcare services, and they experience a greater burden of disability. Now, this comment starts with a disturbing new study that actually came out in 2001, but we know that this is still true today. When a member of a minority group has the same income, insurance coverage, and medical conditions as whites, they receive notably poorer care. Biases, prejudices, and negative racial stereotypes may be misleading doctors and other health professionals. And we're not just talking about race and ethnicity. Another culture that's often very often marginalized is the LGBTQIA+ population. They have a much higher rate of negative health outcomes like depression and suicide, higher levels of drinking, smoking, and drug abuse, infectious disease, and increased risk of heart disease. If you've ever been at a high school or worked at a high school and you had a student or an athlete who came out to you, chances are they were probably homeless because they would have been kicked out of their homes for coming out. And so we need to think about beyond skin color when we're thinking about where this cultural compassion needs to come in. If we look at what negative outcomes exist when we don't have cultural competence, we find things like miscommunication, misunderstandings, and ignorance. Patients benefit when we improve our knowledge skills and understandings to meet their needs. Several slides ago, I asked you to do a self-reflection. Now I want you to go back and to those reflections you had and think overall, how comfortable do you feel working with people that are from a culture that is different from your own? Just because you don't identify with them in a certain way, do they identify themselves in that way? And I'm not just thinking about race, ethnicity. Think about the social determinants of health and how other cultures you come in contact with on a daily basis in your daily practice. Once you understand where you are in the process, you can begin to treat patients based on who they are individually. So this slide, as well as the next one, has a lot of information for you to digest. Again, I'm not going to go over everything individually because there just isn't time. But if nothing else, I want you to start thinking about how you might change your practice based on the patients you see. And I'm going to bring in my example at the free clinic. I see many Mexicans at the free clinic. We have obviously a lot of farms, and so we get a lot of migrant Mexican workers that come to work on our farms. When I have a Mexican patient come in, they will bring their entire family into the treatment room. And my treatment room is small, but I know I've got to have extra chairs for the abuela and the niños because they're going to be there. I also know that their time orientation is very different from mine. If I am not 10 minutes early, I consider myself late. If they're 10 minutes late, they're on time. It's just a very different thing that I have had to get used to. Think about your practice. Do you have a dominant culture in your practice that has some of these different things? Ethnic and religious holidays, traditional and cultural practices. What is the social organization of the family? If you have a dominant culture in your practice, have you tried to learn more about their culture so that you can adjust to meet to them in their place and where they are going to feel more comfortable and appreciate what you can do for them? During your examinations, do you think about what differences you can expect? Can you touch your patient? And do you ask them every single time? Do they express pain Or does machismo take over? Do you make assumptions because of their sex, age, skin color, or religion? Do you dismiss them because they cannot speak English, or they are very poor at their English language? Dig deep. Dig deep within yourself. You may not even realize you do these things, which is why striving for cultural humility becomes very imperative in your practice. Though this should probably be obvious, I'm going to bring it up anyhow. Patient safety should always be at the forefront of our minds. It's probably no surprise that a study that looked at hospitals across the country found that patients with limited English proficiency were more likely to be harmed than their English proficient counterparts when they experienced adverse effects or adverse events, and that the harm was more likely to be severe. Patient safety events that can result from failure to address cultural, language, and health literacy include things like diagnostic errors, missed screenings, unexpected negative responses to medications, harmful treatment interactions from simultaneous use of traditional medicines that the patients might be using, healthcare-associated infections, inadequate patient adherence to provider recommendations, or follow-up visits. Do you use language assistance in your practice? Do you have a qualified foreign language or ASL interpreter or bilingual clinicians or staff? I had a much older woman come in who speaks Spanish, and she brought her 9-year-old granddaughter with her. And that day we didn't have an interpreter. And so her 9-year-old granddaughter who spoke English was my interpreter. Not ideal. Not ideal in the least, because I used words that granddaughter, that 9-year-old didn't know. And we made it work that one day, but that's not what I want to do on a daily basis. Having that interpreter can be very important, especially when you have other language. I've had people come in speaking Farsi. We don't have anybody who can interpret for Farsi. And so we have a program that we can pull up interpreters so that we can understand our patients. You know, have you utilized cultural brokerage and where there's mediation between the traditional health beliefs and the practices of a patient's culture and the healthcare system? Do you have cultural competence training programs to increase cultural awareness, knowledge, skills, whatever you need to lead to a behavior change? If you don't have these things, perhaps you should consider it. You're going to learn a lot, and your patients are going to appreciate you so much more if you can do these things for them. I was doing cupping on one of my patients, and I asked him, I said, do you know what cupping is? His wife could speak English. He was a Spanish speaker. And so the wife would, interpret for me. And I pulled out my cupping because she said, no, we don't do cupping. And I pulled it out and I used the vacuum cups and started doing it. She goes, oh, we do this, but we use fire and glass. I said, no, that's exactly the same thing. You just use a different technique. And it was kind of an aha moment for both of us, because it didn't occur to me that potentially was something that they would know. So how can you cross these cultural boundaries that you may face? Well, here's some pointers to help you. For some of us, this can be difficult because we're so used to doing things one way. And it does take time to make these changes. I've been working at the free clinic since 2020. And I still struggle at times trying to facilitate these cross-cultural facilitations, because it is hard and it does take time. So you've got to give yourself grace, because you're not always going to do what's necessarily right for your patients. And so you can see some of these here. make sure you describe and identify things and then worry about the interpretation later. If you're like me and you use your hands all the time, that's great and helpful because it can help with those nonverbal signs that might be there. Be honest. Acknowledge times when you don't know things, but give your time and attention to communicating. If I have a new patient come in, so I see patients in 30-minute blocks. If I have a new patient come in that is a Spanish speaker, I say I need an hour with them because I don't want them to be rushed during that time that I'm spending with them. And again, give yourself grace. Don't evaluate or judge either them or yourselves because it's going to be tough. This here is a list of questions that can be helpful. They're not ones that you need to use in every encounter. You're going to learn when different questions are going to be helpful. These are just some ideas to help you with your future patient care. Things like, this has become important here, again, with the people that I see. Have you already started doing something for this? Have you done some type of treatment? Is there another treatment you think you should receive? Poultices are things that are used a lot. And they will explain to me, we use herbs and we put them in this hot thing and then we put it on the joint and it, a poultice. That's not the term they use. That's the term I use. And so we have to figure out how are we going to connect that and make sure that we can continue doing it. I have never told anyone what they're doing is wrong, unless it is wrong, which again, they've never been doing, like peyote. I've never had anyone doing peyote, but I've never told them to stop what they're doing if they feel that it's working. I've just made sure that what I'm doing doesn't make them feel like what they were doing was wrong. And so that discussion, that talking needs to come into play. You can't have patient-centered care without cultural competence. You're always going to have an interaction between the two. And so why am I showing you this slide? Because it's the interaction that's going to help you provide the best possible care to your patients. Your services are going to be aligned. You're going to find that your healthcare facilities are convenient to the community you're serving. You're going to have documents that are tailored to your patient needs, literacy, and language. And you're going to start having data that's on performance that is going to help you hopefully receive what you need in order to provide the care that you need to. When you work with your patients, I want you to keep in mind these three concepts. And I know you've probably seen a form of this somewhere, but I still want to go over it because I think it's important to always keep this in mind. Equality means that everyone gets the same thing, the same resources, support, or opportunities, regardless of the individual differences or starting points. Equality is a great word, but do you really meet the needs of your patients if you are looking at just equality? Equity means that people get what they need to reach those comparable outcomes. Your support is tailored to account for the different circumstances, barriers, or levels of need for those patients. Finally, justice goes a step further by removing those underlying systemic barriers that create the inequities in the first place. So the system itself no longer produces unequal outcomes. Where do you want to be in your practice? What do you want to work toward in your practice? In short, equality is the same support, equity is fair support, and justice is fixing the system so support is no longer needed to achieve fairness. I want to conclude with something that is important for all of us to remember. None of us are perfect. We are going to make mistakes, but it's what you do after those mistakes that will resonate with your patient. Acknowledge Others may have different perceptions of what you're saying. Be aware of body language and facial responses to your words, because if someone looks upset or offended, they probably are. Apologize. Address it right away. Say something like, did I say something that offended you? If so, I'm sorry. Please help me learn. Listen to those responses and learn from it. If appropriate, engage in respectful dialogue. Learn why the word or what you said may be offensive. Reflect on the situation. Put yourself in the other person's shoes. Why might this be offensive? Just because it's common and everybody says it doesn't make it right. The first time I ever stood up and did this was way back when I was at the high school, many years ago. And I had a student say, that's so gay. And I had to stop him and say, wait, you can't say that. Well, why not? I said, because you are now saying something that could offend an entire population of people. He goes, well, we don't have gay people around. I said, you don't know that. I said, you need to understand that your words make a difference, and you may not even realize that. And thank goodness he said, you know what, you're right. I will try to stop saying that. I said, no, don't just try, stop saying it. And he kind of laughed, and I never heard it come out of his mouth again. You know, that was, I don't know, 25 years ago. And that's so gay was pretty common in my community. So, you know, maybe I made a difference for one person. Maybe I made it for the entire class because I said it in front of the class. But that's what you need to do. You need to say that, you know, stand up for people and do better. Now you should be more aware of the words that you use. And maybe you should think about using those words again, or saying the wrong thing or doing the wrong thing with hand signals even, or gestures. Be aware of those things and stop and listen to what your patients have to say for you. In conclusion, I really want you to walk away with the idea that patient-centered care is something you're already doing, but it's also something you can improve upon. I hope that you choose to continue to grow throughout your time in the profession, and you always choose to advocate for your patients. Again, here are a lot of helpful resources. I do want to point out a few that I mentioned in the talk. So here's the Harvard implicit bias test. And there's a link, and I know when you get this as a PowerPoint, or as a PDF, you don't get the link. You can just do a search for Harvard implicit bias test, and it'll come up. There are, I don't even know how many, 30, 40 different ones that you can take. And I've taken multiple ones, and it still makes me mad every single time. But here's the link that you want. This is also the article I mentioned, The White Privilege, Unpacking the Invisible Knapsack by Peggy McIntosh. If you just type in white privilege, unpacking the invisible knapsack, for me, the PDF was the very first thing that came up in the search. And then additionally, I also want to make a shout out to Renee Shingles and Lauren Cartwright. Patient-centered care in sports medicine is the newest edition of their book, which originally was called Cultural Competence in Sports Medicine. It is through Human Kinetics. A lot of the information that I put into this presentation is from this text. And if you're going to get one reference, this is the one I want you to get. You can probably get a previous edition, you know, for a used book pretty inexpensively on, you know, textbooks from Barnes & Noble or wherever you happen to get your texts. But this book is amazing, and they did such a great job because it is focused specifically on athletic training. So I just want to thank you again for the opportunity. This is my email, and I would be happy to answer any questions or assist you in any way if things come up in the future. But I'm going to stop sharing now and answer any questions that people might have.
Thank you. And I'm going to put the CEU link in the chat for anyone that needs that to fill it out. And I did do the Harvard implicit bias for Dr. Moffit's class, and it is really cool. Some relevant stuff to people on my site, and then I just did some others that I just felt like were good to know for my personal interest, and I thought that was really cool and kind of uncovered some things I hadn't realized. So I would definitely recommend that to anyone.
Thanks, Megan. Yeah, it is eye-opening, and again, it's been validated. And so you can sit there and think, no, they don't know me. How did they know? It's true. And it can be very, like I said, I redo, there's 2 that I redo all the time, hoping that I've made a change in it. And it's inching better, but it's still showing me that I have a lot of learning to do. I'm watching the time. I know you have to be on for so many minutes for you to get the full 1 CEU. So let's talk. We've got like 3 minutes we got to get in here so that you get your full CEU.
So I guess I'll just take advantage of the time now, but so we're kind of restarting our DEI committee here at work. So we have a meeting tomorrow. We had a kickoff meeting last week just to see if there's interest in it. We are doing a meeting tomorrow to talk about what kind of our plans would look like. And our focus is mainly on increasing the like psychological safety and feeling of belonging within our company and increasing diversity within our company. Is there anything you would recommend or ideas you have that I could look into to share with the committee?
And this is for your employees specifically?
Yep.
There are a lot of different things that you could do for the well-being, employee well-being. And I think probably one of the best is to have your employees do a self-reflection. And you literally could take any of these slides and pick up some things that they can look at themselves. But one of the things that I've done in the past with people is I've had them create Wordles, and you can go online, they're free, but have them put in words of the culture that they are, and don't give them any information, and see what comes up, and then explain to them, remember, your culture can be more than race, ethnicity, gender, religion, because you're going to find, this is how you find those relationships between people. When I do this, I put culture. I am a teacher. I am a healthcare provider. I am a swimmer. I am a mother. I am, these things that then people can begin to see where their relationships are and how things become, how we're more similar than we are different. And that's one of the big ways to really open up their eyes. I can also, I can send you some links to some other online things that you could do.
Sure.
But I think that is a great way. And I think the activity that I did at the beginning, which again, I would literally have people do that activity and have them have the 5 pieces of paper, flip them over, and make somebody else choose the one identity, so that they don't get to choose one of their most important identities being taken away, so that they can begin to understand how people don't feel part of a community and how it can be taken away from them. And then that's what really starts the conversation, some of those activities.
Cool. Yeah, that sounds good. That first activity, that was really interesting, just to think about what does it look like when you take away those parts of yourself that are so foundational. Now you don't get to have that, and how that must feel for other people.
Yeah, absolutely.
I had a quick question. Remind me again how to find that quiz. Will we get the slides after the meeting sent to us or?
I sent a PDF
Okay. I just haven't
to
got it yet.
Michael, so
Okay.
he will probably get it. But if you just do Harvard implicit test,
Okay.
you can just do a quick search and it'll come up for you.
Okay. Thank you.
You're welcome. To
I'm
say,
gonna see
I wonder if I
throw
can
the
put
link
it-
in the chat. Yeah.
I was just going to say I could throw the link in the chat
Find
also.
it.
Here,
I have a question for you guys.
absolutely.
So one thing that I've definitely seen a lot more probably in the past 5 years than I would say I saw before, but it probably has just been as relevant, just as, prevalent. I just in my experiences with people. But how do you kind of work with deconstructing belief statements from patients? Because it can be anything. Like I don't believe in vaccines. I don't believe in opiates. I don't believe in going to the doctor. I don't believe, right? And this is something, it's not so much like, oh, I haven't taken this or I prefer not to engage in this thing, but really is something structured around a belief that makes the conversation a little more complicated when it comes to trying to really get to, usually it's driven by these deeply held assumptions, right? But you can offend when you're trying to educate. So I'm wondering if you have any advice for managing those statements, because I get them a lot.
That is so tough. And the big thing is you always want to make sure the person knows that you will not try to remove their belief by not remove isn't really the word. You don't want to negate their belief, but you also want them to know that you have beliefs, and would they be willing to consider? And what I mean like this, you could say, okay, you don't believe in healthcare, and you know what? You probably have a reason to not believe in healthcare, and that's okay. You need to understand I'm a healthcare professional, and so I believe in healthcare. And so we've got two different beliefs going here. What can I do from my end that you would be willing to try to overcome your reasoning for why you don't want this? For example, immunizations. You don't believe in immunizations. What can I do, or what are you willing to try immunization wise? If they don't want to try anything, you have to stop there and say, okay, that's fine. You need to understand where I'm coming from, but I am not going to tell you that you have to change. Now, if it's something like you have to have this immunization or you can't work here or you can't be a part of this, you have to understand that our core belief system says that you have to do this. And so you have to make a choice if you want to go with your belief system or our belief system. And I'm not going to tell you which way you have to go. You have to make that decision yourself. And you just have to put the impetus on them to decide whether or not they want to have that conversation. If you can do it in a way that is non-confrontational, they're more likely to talk with you, unless they have been in those confrontational situations over and over and over, and they're already coming in with a chip on their shoulder. And then you can't do anything about that. And so all you can do is try to have that conversation and let them know that you are willing to have the conversation, but they also have to be willing to have that conversation as well. Does that help?
Yeah, I think it does. It's definitely an approach that I'm going to try and see how. I think the science in me, I think I've attempted some versions of that, and I do definitely get kind of the emotional response. The last year or so, especially as vaccines have become something I hear a lot about, right? Is saying, okay, do we both agree vaccines exist? Okay, so we know this is a thing. and trying to lead them to realize there's a practical reason for why they hold this belief, right? So, okay, so what about vaccines? Since we know they exist, so believing them or not is not, the question. What about them concerns you? And trying to help guide them to, oh, I don't feel like this is thoroughly researched or backed, or I'm concerned about side effects, and trying to kind of deconstruct it from an emotional, because we are naturally emotional people,
Yes.
And so that has kind of, sometimes it works, but I've definitely had some really, oh yeah, my doctor put me on blood pressure medication, but I don't believe in that. And then going, okay, what is that? Okay, you see the meds exist. Talk to me about what it is about the medication, and trying to kind of work backwards. But it's definitely become increasingly tough over the years to, trying to forge that path.
It is. And, there's people out there say, well, make sure that you have, an article they can read that they're not going to read it.
Yeah,
And,
definitely not.
And things are really ingrained. That's the reason the implicit bias test, the Harvard implicit bias test is so right, is because things are hardwired into us. And so you can only do what you can do. People are going to make the decision whether or not to change their mind. And, it's tough. It's tough.
This concludes the IATS On Demand Continuing Education Program video. To claim your CU, you must be a member of the Industrial Athletic Trainers Society and complete the From Claim Your CU found in the YouTube description. If you have any interest in learning more about what the Education Committee has to offer, reach out to the email address on your screen. If you would like to volunteer your time to speak on a topic that interests you, please reach out. Thank you and stay safe.